Um, Hello, everyone. This is Khadija Al-Musalh. I'm a surgical resident at Oman Medical Specialty Board. I'm glad that I will present for you a case report that we have published last year. It is about its name, unusual presentation of genitourinary and gastrointestinal metastases from invasive lobular carcinoma of the breast. I'm presenting this in behalf of my colleague. I hope you will benefit from it. So this is where it was published. It was published in International Journal of Innovative Research in Medical Science in July 2020. So what is the table of contents that I'll present today? So I'll talk first about the abstract and introduction of the case report, and then I'll talk about the case details. Then the third part is discussion and literature review that we have done at the end, the conclusion. So the abstract, unlike invasive ductal carcinoma, lobular carcinoma exhibit a distinct metastatic pattern. It's likely to spread to gynecological organs, peritoneum, retroperitoneum, brain and gastrointestinal tract in comparison to ductal carcinoma, which spread to liver, lung, and brain tissue. The diagnosis becomes more unlikely on the rare occasion when it represents the first manifestation of breast cancer. It's important to differentiate the metastasis from primary carcinoma of genital or GI tract, as the management substantially differs. In this report, we present a 47-year-old female patient who presented with gynecological organ and gastrointestinal tract involvement as initial presentation and literature review done for these unusual sites of metastasis. So first, in introduction, the incidence. So invasive lobular carcinoma account for 5% to 15% of newly diagnosed breast cancer. Its incidence is increasing. And how the patient present? So 60% of patients with invasive lobular carcinoma will already have metastatic disease at time of diagnosis, while 30 to 80% of patients will develop metastatic disease following surgery and or systemic therapy or radiotherapy. The pattern of metastasis, the pattern of metastatic spread differs significantly between invasive lobular carcinoma and ductal carcinoma, where lobular carcinoma tend to exhibit unusual sites of metastasis. It's likely to spread to gynecological organ, peritoneum, retroperitoneum, brain, and gastrointestinal tract, in comparison to ductal carcinoma, which spread to liver, lung, and brain tissues. Now I'll present or I'll talk about the patient details. So which this report we have done. It was in 2018 when a lady, she was 47-year-old, premenopausal, with no past medical history, and she's Romani lady, presented to a Department of Gynecology at Sultan Qaboos University Hospital with 2 months history of abnormal uterine bleeding. She was asymptomatic for anemia and she didn't receive any blood transfusion. On physical examination, she was found to be pale, but her vital signs were normal. Pelvic examination revealed hard hypertrophied cervix, which was flushed into the vagina. In addition, there was a vulvar mass. There was no history of rectal bleeding or gastrointestinal symptoms. Laboratory values revealed low hemoglobin of 8.5 gram per deciliter with normal platelets and white blood cell counts. Chemistry panel was normal. Pelvic ultrasound revealed a 30 mm dilated endometrial cavity by blood clots. Pap smear was done and it showed poor cellularity. She had an endometrial biopsy that revealed scanty atypical cells suggestive of neoplastic epithelial lesion. So further workup was done. So she underwent MRI pelvis. MRI pelvis, this picture showing T2 sagittal view, which showed diffuse T hypointensity of the cervical stroma with loss of zonal anatomy. diffuse thickening of the junctional zone. There is circumferential mass seen in the rectum, mild ascites with T2 hypointense nodular thickening of the peritoneal reflection, dam of the urinary bladder, heterogeneous signal of the bone marrow. Gardner duct cyst is seen also. On subsequent rectal examination, the rectal mass was filled. Then she underwent repeated hysteroscopy with endometrial sampling and cervical punch biopsy. She had diagnostic colonoscopy done by gastroenterologist demonstrating fungating, friable, circumferential, non-negotiable mass started distally at 4 centimeters from the anal verge. Multiple biopsies were taken, and the pathology report from all biopsy sites, including rectum, endometrium, vulva, and cervix, revealed poorly differentiated neoplasm consistent with metastatic breast lobular carcinoma, estrogen receptor positive, progesterone receptor positive. And this is a picture from histopathology picture, hematoxylin and eosine stain with 100 magnification showing cervix involvement. So this is cervix by metastatic lobular carcinoma. The subepithelial stroma is densely infiltrated by malignant cell. This is another hematoxylin and eosine stain of biopsy was taken from the labia. And it showed also dermis is densely infiltrated by malignant cells. Following this, she was evaluated by breast surgeon, and upon further questioning, she reported to have 1 year history of bilateral breast hardness with the changing in shape and size. She had never brought it to anyone's attention. Reproductive history consisted of menarche at age of 13 years. She had 2 children with first live birth at age of 34 years, no history of taking combined oral contraceptive pills, and no family history of breast or ovarian cancer. She has never had screening mammogram. Breast examination was performed and revealed asymmetrical breast with left side smaller inside and distorted compared to right side. The left breast was occupied by big, hard, fixed, immobile mass with skin nodules. The right breast also was occupied by big, hard, fixed mass, but it was mobile and associated with the skin thickening, but no skin nodules. She had bilateral fixed axillary lymph node and left supraclavicular lymph node. So these are pictures of her breast examination. As we can see, this picture is showing there are asymmetrical in the breast with skin changes, and here the hard mass can be appreciated from inspection. This is mammogram that she had it. So it is mediolateral oblique views. There are bilateral dense irregular masses with indistinct border associated with diffuse skin thickening, with tethering in some areas. The nipples are flat. Polymorphic calcification are seen in left breast mass. Following this, true cut biopsies from both breasts were performed and showed invasive lobular carcinoma, grade 2, and no in situ carcinoma. Estrogen receptor and progesterone receptor immunohistochemistry were positive. HER2 immunohistochemistry was negative, and the proliferation index, Ki67, was 40%. Fine needle aspiration from both axillary lymph nodes revealed atypical cells suspicious for malignancy. And these are the histopathology pictures of here from the breast, which showing invasive lobular carcinoma, and here is the estrogen receptor immunohistochemical of the malignant cell, which was positive. She underwent further investigation with staging CT chest, abdomen, and pelvis. Showed, in addition to the non-rectal and uterine cervical mass, subcutaneous soft tissue deposit, right and possibly left orbital metastatic involvement, multiple bilateral cervical lymph nodes, moderate bilateral pleural effusion, mass lesion is seen infiltrating the left kidney and the tail of pancreas, nodular appearance of adrenal gland, mild to moderate bilateral hydronephrosis, there are extensive patchy mixed lytic and sclerotic bone lesions. Bone scan showed widespread, diffuse, and extensive metastatic deposit involving almost the entire exoskeleton, including the proximal upper and lower limbs, sparing the skull. MRI brain performed shows significant infiltration of the bilateral orbital muscles noted along with suggestion of heterogeneous lesion noted along right lateral globe, along with compression of the intracranial part of bilateral optic nerves, bony infiltration of bones of vault of skull and skull base, no defined brain metastasis. And this RCT scan, so the one this one showing diffuse enlargement of extraocular muscle associated with exophthalmos, and here is the CT cross-section CT abdomen, moderate ascites with rim enhancing mass in left kidney. The final diagnosis was de novo metastatic lobular carcinoma of bilateral breast with extensive metastasis to orbit, subcutaneous tissue, bone, kidney, pancreas, adrenals, rectum, peritoneum, cervix, uterus, and ovaries. She was staged clinically for the breast cancer as left breast T4 C N3M1 and right breast T4P N3M1. Cystoscopy and bilateral digest ureteric stenting was performed by urologist. She was treated with palliative chemotherapy using palbociclib, denosumab, and letrozole. Now this is about the case. We are moving to discussion and the literature review that we have performed. First part is about difference between invasive lobular carcinoma and invasive ductal carcinoma in terms of metastatic pattern. Then I'll talk about invasive lobular carcinoma and metastatic to genitourinary system, and then invasive lobular carcinoma and metastasis to the gastrointestinal system. Now, our patient presented with metastasis to bones, genitourinary system, and gastrointestinal system. This pattern of metastasis is supported by the prospective study, which compared the pattern of metastasis between invasive lobular carcinoma versus invasive ductal carcinoma. Invasive lobular carcinoma had more frequent metastasis to the bone, with 56.8 versus 37.7%, which was significant. Ovarian, it was 5.7 versus 2.1%, which was significant. And gastrointestinal tract, 5.7 versus 0.3%, and less to organs such as lung and liver. In another study which followed the patient diagnosed with breast cancer for 24 years, it was found that invasive lobular carcinoma was associated with an increased incidence of bone event, but a decrease in regional and lung event, which was statistically significant. Same study showed that patients with invasive lobular carcinoma were older compared to invasive ductal carcinoma, more frequently with estrogen receptor positive and less vascular invasion compared to our case. The patient was young, she was estrogen receptor positive and had no vascular invasion. And this is a table which compares the metastasis pattern between invasive lobular carcinoma and invasive ductal carcinoma, which conclude the same as I mentioned before. The metastasis in the female genital tract from extragenital primary tumor is uncommon, and it was there was 325 cases analyzed in 1984 of metastasis to female genital tract. The majority of the extragenital primaries metastasizing to gynecological organs were adenocarcinoma from gastrointestinal tract. They originated less frequently from the breast and other organs. In literature review, lobular histotype seems to metastasize to genital tract more frequently than ductal tumors. The incidence of invasive lobular carcinoma metastasizing to genital tract is 36 to 52% in autopsy series and 2% to 5% in clinical series. In 1988, 63 cases were published of metastatic cancer to uterine corpus from extragenital neoplasm. The most common primary metastasizing to uterus in this series was breast cancer with 47.3%, which was found interestingly that myometrium was found to be involved more than the endometrium. Abnormal vaginal bleeding may be a sign of neoplastic uterine involvement, although this is also infrequent. This may include abnormal duration of periods, bleeding between periods, and postmenopausal bleeding. Now, is it common to see metastasis to cervix? Breast cancer metastasizing to cervix is very rare. Common tumor metastasizing to cervix are gastrointestinal tract and ovarian cancers. Only a few cases have been reported so far. Considering the rarity, the actual incidence of cervix metastasis is unknown. In this literature, most of the cases of breast cancer with genital tract metastasis occurred in advanced breast cancer while on tamoxifen treatment or during follow-up. There are only a few cases where genital tract involvement as initial presentation was reported. And this highlights the rarity of presentation in our case. Now I'll move to invasive lobular carcinoma and metastasis to gastrointestinal system. The breast cancer is the second most common cancer to metastasize to the GI tract following malignant melanoma. Although GI metastasis from invasive breast cancer is rare, less than 1% clinical practice, the incidence might be underestimated and is likely to increase. Autopsy series report a rate of GI tract metastasis up to 15%. It rarely metastasizes to the colon or rectum, more commonly metastasizing to the stomach or small bowel. GI metastasis is usually associated with extensive systemic spread. In big series, invasive lobular carcinoma was more likely to give metastasis to GI tract than invasive ductal carcinoma, with incidence of 4.5% and 0.2% respectively. Sites of metastasis can vary from oropharynx to the anus. Anorectal involvement is very rare. Rectal metastasis from invasive lobular carcinoma usually occurs 5 to 7 years after the diagnosis of the primary tumor, but there have been cases reported with synchronously rectal metastasis, as well as metastasis up to 20 to 30 years after diagnosis of primary invasive lobular carcinoma. 337 autopsies on patients who died of carcinoma of the breast published in 1968. 52 cases of these 337 were GI metastasis. The distribution of this metastasis was as follows: esophagus with 25%, stomach 25%, small intestine 28%, colon 19%, and rectum was 4%. The literature which have been published showed also that stomach is the most common site of gastrointestinal involvement by metastatic breast cancer, specifically lobular form, with an incidence of up to 15% on autopsy. Mostly, it is hematogenous metastasis, but involvement via peritoneal and lymphatic spread also occurs. The time interval between primary breast cancer and gastrointestinal involvement may range from synchronous presentation to as long as 30 years, but reverse is also true, with the GI manifestation preceding a diagnosis of breast cancer. The clinical manifestation that metastatic breast cancer to the GI tract can have are variable. Symptoms may range from non-specific complaints to acute GI symptom and may be considered treatment-related or as inflammatory GI disease. They can also mimic a primary cancer of the GI tract, which is more common than isolated GI metastasis of primary breast cancer. The diagnosis becomes more unlikely on the rare occasion when it represents the first manifestation of breast cancer. In our case, the patient was asymptomatic and rectal lesion was detected only in MRI pelvis. It's important to differentiate the metastatic from primary carcinoma of genital or GI tract, as the management is dramatically different. The histologic diagnosis of the secondary deposit is crucial for the correct diagnosis. The histological recognition of lobular carcinoma at the metastatic sites may be difficult. Nevertheless, in our case, the metastatic sites maintain their characteristic to the primary. Markers that help confirm the diagnosis are gross cystic disease fluid protein 15, estrogen receptor, and progesterone receptor. These markers are positive in metastatic lesions of the breast, in contrast to most colorectal or gastric carcinoma, which are usually negative. Studies have found that invasive lobular carcinoma are more likely to be estrogen receptor, progesterone receptor positive than ductal carcinoma. HER2 protein overexpression or gene amplification have been reported less than 1% to 6.2% of all invasive lobular carcinoma cases. Few invasive lobular carcinoma cases, like 1.5%, exhibit a triple negative phenotype. Our patient was positive for estrogen and progesterone receptor and negative for HER2 protein. Systemic treatment with chemotherapy, endocrine therapy, or a combination of both is usually started in patients with breast cancer that metastasize to the GI tract. Surgery should be limited to cases with complications such as stenosis or obstruction or for obtaining a diagnosis. Remissions are observed in 32 to 53% of patients. Survival after diagnosis of GI metastasis from a breast primary is poor, with few patients surviving beyond 2 years, although survival up to 9 years has been reported. Now, the conclusion. This case highlights the importance of understanding the invasive lobular carcinoma has a unique pattern of metastasis compared to most other types of breast cancer. A high index of clinical suspicion should be maintained for unusual pattern of metastasis. Metastatic spread should be considered in the differential diagnosis of patients with invasive lobular breast carcinoma presenting with abnormal vaginal bleeding or GI symptoms. Accurate diagnosis is essential as the treatment for primary genital tract or GI carcinoma and metastatic lobular carcinoma are different. Thank you. As I said, I have presented this in behalf of my colleague in Sultan Qaboos University Hospital, which their names mentioned here. And these are the references that we have used in our literature review.